Thank you very much, everybody, for joining the Acute Flax Encephalitis Working Group, and welcome everybody who is new, including Martin in Senegal, who is from Senegal and is joined the Acute Flax Encephalitis Group. We really appreciate your participation in the working group focused on acute flax encephalitis. We are trying to continue our plan of education and training and awareness about acute flax encephalitis, not only in the United States, but also around the world. And again, thank you very much for our colleagues in Africa, in Europe, in South America, and the United States that are joining the meeting. Today, we are having, once again, the pleasure to have Dr. Janell Routh, who is the acute flax encephalitis poliovirus team at the CDC. And I asked Dr. Routh to give us an update not only about acute flax encephalitis, but also about polio. And it's going to be a very interesting opportunity to discuss how we are going to be prepared in the next few months about AFM, but particularly also to be aware about other viruses that are emerging or re-emerging. And I think that that would be a very good opportunity for discussing about these topics. So Janell, again, thank you very much.
All right, Carlos, thank you so much. And good afternoon, everyone. Good morning in other parts of the world. Nice to see everyone, and thanks for making the time. I know this is summer holidays for many people, so it's great to see so many folks on. Yes, as Carlos mentioned, my presentation today is twofold. First, I'd like to talk about where we stand with AFM case surveillance here in early July. And then also I'll talk a little bit about the poliovirus outbreak response in Africa. I was really lucky to be able to go to Malawi and assist with their response to the first case of wild poliovirus type 1 that they've seen in over 20 years in that country. I was there just a little after May 1st through mid-June. This is also a country where I've spent 6 years of my life, first as a Peace Corps volunteer, and then with the Baylor Pediatric AIDS Corps as a pediatrician. So a great opportunity to go to what I consider my second home. I speak the language and still have really old friends there. So it was nice to go back and see everyone. The last time I was in country was about 10 years ago. So what I would like to do, if I could get these slides to advance, is to speak briefly about an update on where we stand with AFM case surveillance. And then for the second piece, I'll describe the current situation of wild polio type 1 cases in Africa, the overall response to efforts through the Global Polio Eradication Initiative, and then I'll talk a little bit about what I did during my 5-week deployment there. So first, let me give an update on where we stand with AFM case surveillance. You all are familiar with this epi curve that takes us from our first foray into AFM surveillance in August of 2014 through July of 2022, with a total number of confirmed cases of 686. For this year specifically, 2022, we have received reports of 18 persons under investigation for AFM. We've confirmed 8 cases. We've considered 2 to be not cases, and then we're awaiting classification on an additional 8 cases. 4 of those are out with our neurology panel for review, and then for an additional 4, we're awaiting information. Just to note, we have not had any viruses isolated from specimens that have been sent to CDC from these cases, and of note, we haven't received any specimens testing positive for EVD68. From our Sentinel surveillance system, we have seen a few sporadic reports of EVD68, but nothing that is suggesting an uptick of that enterovirus at this time. And I might take a pause and see from others on the call if you have any additional information to share about EVD68 detections, but that's what we know so far from CDC.
Hey, Janell, I can jump in. I guess this is like third hand, so take it for what it's worth. But I was at the positive strand RNA virus meeting 2 weeks ago and talking to some Katja Wolters, who has a hand in some of the European surveillance. And she also had said, I think along the lines of what you were saying, which is they'd been seeing some EVD68, but there was not any defined surge or anything like that. So it sounds like at least again, third hand or second hand, but it sounds like they're having a similar experience.
Matt, that's great to hear. I think, one thing that we are trying to do over time is to become more in communication with our European colleagues and have learned a lot from their surveillance efforts for enteroviruses and EBV68. So good to hear that brief report as well. Here is our state map of case locations of confirmed cases. We've got 4 so far in California, and then a few other cases scattered throughout the country. Kind of typically what we see in our off-peak time. And then I think I've shown this slide before, but just to refresh everybody, we do track AFM activity by the number of reports of suspected cases, those persons under investigation that we receive from health departments and then are reported to health departments by clinicians. So keep in mind when you look at this, these are not confirmed cases like we show in our EPI curve, but reports of suspected cases sent to CDC for classification. And this is really as close to real-time activity tracking as we can get. So the peak year report averages are highlighted by the line in blue. And so you can see that uptick of activity when we get into our AFM outbreak season, which was typically in the fall, late fall time period in 2014, 16, and 18. And then the reports for 2021 are highlighted by the yellow line. So again, we kind of consider those non-peak years to be our baseline years. And you can see that there's really not an increase in reporting at any time during a non-peak year. And then our current reports are shown in red. So the red line represents 2022 reports. And right now we're really at our expected baseline for this time of year. As with many other viruses that have started to circulate this year, we're not quite sure when we will see EBV circulation and whether we'll see it outside that normal summer period. But as we are in July, we're certainly on high alert for an uptick in case reports as well as reports of EBV68. So I just wanted to run through briefly some of the activities we're doing this summer for both outbreak preparedness and awareness. Certainly, we continue to work with our health jurisdictions to enhance AFM surveillance. There's a lot happening right now. COVID is still ongoing. There's monkeypox now. But our team effort is really to make sure that our jurisdictions are aware we're rolling into those summer months and are definitely looking for reports of AFM to come in. We're preparing draft materials. Again, if we do roll into an outbreak response, we would immediately do a COCA call and then send out health alerts and EpiX reports to our clinicians and to our state epidemiologists. So those materials are drafted and we can be able to send those out as soon as possible should we see an uptick. We're in the process of educating clinicians. I think, this whole group is really aware of the push that we need to increase awareness for AFM. We've got those American Academy of Pediatric Microlearning sessions up and running. We are working on some newsletters for professional societies, including the American Academy of Pediatrics, media buys, and then social media posts as well will start going out this summer, particularly because July is AFM Awareness Month. So we want to make sure we match up and push awareness during this month. We are always updating our AFM website to include new language as we learn more about AFM and then promoting our new communications materials. We did just publish our AFM children's book, which looks fantastic. I should have put a picture of it up on the slide set, but it's great. And we are going to be in the process of disseminating it out to our sRNA partners as well as others. Continuing to collaborate with you all, our AFM experts, partners, and parents, really to make sure that we are touching every point that we need to raise awareness, and certainly very open to dialogue with any of you if you feel like there are things that we could be doing. Please don't hesitate to reach out. We are going to be publishing an MMWR on our 2021 AFM surveillance data. I'm not sure when that will be published, but just wanted you to know that is in process. We are going to be conducting an internal, what we call a tabletop exercise. So this is the time for us at CDC who would be involved in an outbreak response to kind of run through our motions and procedures to make sure that we've got everything smooth and ready to go should we need to roll into an outbreak response at this time. And then finally, exciting, we do have, it's an emerging infectious disease conference that's scheduled for early August, and there is an AFM panel in that conference. Kevin Messakar, Claire Midgley, and Kim Benshop will all be speaking at that panel. So again, looking forward to really raising awareness in that community through these panel talks. So with that, I'm going to pause and just take any questions that people might have about AFM and surveillance or any of the other AFM activities that I've mentioned, or maybe give folks a time if they want to share any additional AFM awareness activities that are happening during this month. So I'll take a pause, Carlos, and see if others would like to share.
Thank you, Janell. Any comment, particularly about AFM cases or enterovirus circulation? I know that Jelte joined the meeting, so I don't know if there is any report from Europe or if our colleagues in Japan or in Africa have additional comments.
Well, from Europe, as you already mentioned shortly, there's no new AFM case in the past month, and enterovirus D68 circulation has been low, at least in the Netherlands, and as far as I'm aware, in Europe as well.
Also, any problem with AFM or enterovirus in Turkey? Great. Janell, I think that we should continue with the next.
All right. I might, Rebecca, I don't want to put you on the spot, but is there anything from SRNA that you might want to mention to this group?
Sure. I can quickly go through some of our updates if that works for everyone, but SRNA is going through with AFM Awareness Month for the month of July, dedicating social media space to continuing to raise awareness of AFM, highlight family stories, and promote the recognition of AFM signs and symptoms to families and healthcare providers. So please feel free to share the posts from our various social media outlets, including LinkedIn, to help disseminate that information. As part of AFM Awareness Month, SRNA is hosting a special AFM Awareness virtual meeting along with the Acute Flaccid Myelitis Association, or AFMA. So we'll be featuring expert panel of clinicians and researchers from this group, as well as families and individuals diagnosed with AFM. So it'll also include an opportunity for breakout sessions for more personal connection time amongst families and medical professionals. And I'll include a link in the chat so that you all can have an opportunity to sign up or share it with your networks and families. We're also planning a special and separate kid-oriented online event that'll likely take place in August, where we'll hopefully have an opportunity to go over some materials that we've developed specifically for children and invite an author to read to them as well. So keep your eyes and ears open for that detail to come. And SRNA Family Camp is on track. We're excited and looking forward to getting together with our families and a few of our medical professionals starting July 26th. So there are a couple of spaces available if any of your families are still interested. And if so, since we're closing in on that start date, please let me know and I can assist with that application process. Another thing to keep in mind is SRNA's RNDS, or Rare Neuroimmune Disorder Symposium, is on track for planning and is set to take place in October. So that'll be another great opportunity for families and clinicians alike to learn more about AFM and receive updates. Our AFM physician consult portal is still open and ready to receive inquiries should there be a need. So please continue to keep that in mind as we move through the summer and into fall. And lastly, SRNA is also partnering with Neurology Live, and we'll be featuring an AFM dedicated podcast. So I'd love to hear from any within this working group who'd like to be featured in this particular podcast, as well as for an AFM update for SRNA Ask the Expert series. So please email or give me a call if you're interested. I'll put my email and number in the chat and we can set that up. And if there are any materials or needs you've identified for your families that SRNA may be able to assist with, please don't hesitate to ask.
Thank you, Rebecca. And for the group, SRNA is very active in the community of patients with myelitis and other rare neurological disorders. So when you get an invitation for a podcast, please accept that. It's a podcast that is very well received among families and patients, and the website is also very helpful and for information and education. Janell?
All right. Let's transition then to the second part of my presentation today. So at the request of Carlos, this is to discuss the response to cases of wild poliovirus type 1 that were first discovered in Malawi and then subsequently in Mozambique. I'll just say my disclaimer is that I'm not a global polio expert, although I know several people on the call are and have much more poliovirus experience than I do. So Amy, I'm looking at you. Please do feel free to jump in with any questions or corrections that I may have in my presentation. And I'll try my best to monitor hands, but do feel free to jump in. I want this to be as informal as possible. So since we have a wide audience, I did want to give a bit of a background on poliovirus and the disease caused by this virus, which is a disease really clinically similar and radiographically indistinguishable from AFM. It's caused by 3 types of enterovirus, types 1, 2, and 3. And for a lively discussion on the meaning of serotypes, you can join Amy and Vince in their This Week in Virology netcast on this very topic. I think it's episode 866, and it took place in February, and lots of good information there. Poliovirus is spread by the fecal-oral route in endemic countries, and suboptimal sanitation and crowding definitely increase transmission. It's highly infectious, and about 90 to 100% of non-immune household contacts will be infected from that source case. Its seasonality is summertime. Probably a few of us on the call remember summertime polio outbreaks historically here in the United States. And that summertime seasonality is most often seen in temperate climates like the one we have here in the US and in Europe. Poliovirus doesn't really have a seasonality in tropical climates, although higher transmission does take place during the rainy season when I think there's more room for waterborne contamination. Approximately 75% of poliovirus infections are asymptomatic, which can make things challenging when looking for case contact. 25% of polio infections can cause a flu-like symptoms or GI illness. And then it's really less than 1% of infections that do go on to cause that irreversible paralysis, again, similar to what we have seen with acute flaccid myelitis. This can be permanent muscle weakness or complete paralysis. It can affect one or more extremities, and usually with poliovirus, it does tend to affect the lower extremities in an asymmetric distribution. And then just like we know with AFM, usually sensation and sensation are unaffected. So this slide is courtesy of Kevin Messakar. He's not on today to see me poaching his slides, but acute flaccid weakness and paralysis has really been present since ancient history. Sporadic infantile paralysis was depicted back to 1500 BC. And on the right, here's a Egyptian stele or a stone monument depicting a person with lower limb wasting and paralysis that I think was likely to depict polio. The syndrome did become endemic in Europe and North America in the late 19th century. And then in 1908, the cause of many of these cases was discovered. So poliovirus was discovered in 1908. And
it was
then
isolated.
Thank you. Yes, Amy, thank you. See, I knew that we were going to tag team this presentation. So
I'm glad to see that my steel picture and everything went to Kevin is being well used.
It's made its rounds throughout this group. And so, yes, as I mentioned, those summer polio epidemics were common in the US throughout the first half of the 1900s. So there's a lot of information on this slide, but I did think it was important to give a few points on the two types of vaccine that are approved for the prevention of poliomyelitis: the inactivated polio vaccine, or IPV, and then the oral polio vaccine, or OPV. And, again, I think part of the complications around the eradication of poliovirus actually stem from these two different vaccines. So inactivated poliovirus vaccine was authorized for use in 1955. It's given by intramuscular injection, and it's relatively expensive. It costs about $2 per dose. It is in the current US immunization schedule, and that schedule recommends a 4-dose series for children. IPV confers an IgG-mediated immunity in the blood. So this prevents poliovirus infection from progressing and infecting the motor neurons. It does not produce mucosal immunity, and therefore it does not protect against infection and viral shedding. Although I think we know from studies it does reduce viral shedding, but it does not completely stop it. And Amy, I will just pause and see if you want to add anything.
So IPV leaves your intestines completely vulnerable, and you are able to be infected and replicate actually to pretty high levels. It's also based upon the idea that there is a viremic phase to polio, which was identified by David Bowden at Hopkins in the 30s. And so it really prevents the neuroinvasion of the virus. And one of the things about IPV is that it's also, for really good protection by IPV, you have to be exposed to infectious virus. And this was work done by Marianne Koopman's lab in the early 90s. So really, to get an effective immune response using IPV, you do have to have some kind of OPV first or after, or some kind of exposure to infectious wild type. Which is why when the switch was originally made, they had discussed making IPV following at least 1 dose of OPV.
Amy, thank you. No, I think those are incredibly important points. And I think then really provides a nice contrast to the oral polio vaccine, or OPV, which is an attenuated vaccine that was authorized in 1961, so a little bit later than the inactivated vaccine. It's given orally as 2 drops, and the really nice thing about the oral polio vaccine is that it's quite cost effective, so it's just 15 cents per dose. This was the predominant vaccine used in the United States until 2000, when the recommendations were changed to an all IPV regimen to prevent what we call vaccine-associated paralytic polio, or VAP, which is polio that can occur if that oral polio vaccine reverts back to a wild phenotype, which is rare, but again, can occur, and one reason why inactivated vaccine became the preferred vaccine through the United States and Europe as well.
So just to make a slight correction.
Thanks, Amy.
All OPV reverts. So all OPV reverts. It's few cases of VAP and circulating vaccine-derived polio that circulate, but all OPV reverts to the neurovirulent form, and it's a single point mutation that tends to be at the 5' untranslated. And this was demonstrated very elegantly by Phil Miner in the 80s for type 3, and then subsequently for type 2 and 1. So they all revert to a neurotropic, neurovirulent form.
Amy, thanks. And again, very important in kind of describing now the epidemiology that we happen to be seeing currently around the world for poliovirus.
Yeah, so we tend to see a lot of, in areas of eradication where vaccination levels drop to 90%, and when you come in with and you see a polio case, it generally tends to be associated with circulating vaccine-derived polio virus. And it has a signature that you can easily identify by nucleic acid restriction digestion and various other things. So it is a significant problem in the fact that it does reseed the population with a paralytic form of the virus.
Right, excellent point. You know, some of the benefits to the oral polio vaccine are really that it does confer that mucosal immunity. So, you know, again, Amy mentioned with IPV, you can prevent infection. Sorry, you can prevent neurovirulence, but you can't prevent infection. OPV does the opposite. So you can really develop a mucosal immunity in the gut that can protect against primary poliovirus infection, certainly in areas where poliovirus is endemic and it's mostly spread fecal orally. And then the other benefit of OPV is that vaccine virus can be shed in the stool and provide passive immunity to other unvaccinated individuals and confer partial immunity to them in the community. Now, again, there's that balance between that benefit, but also the risk, again, of shedding neurovirulent OPV into the community as well. That said, this is the vaccine of choice for most developing countries or countries with poliovirus outbreaks. And so just a couple slides to show our progress with using these vaccines. So after the US saw polio vaccine introduction, first with IPV and then with OPV, cases of poliomyelitis and vaccine-associated polio, or VAP, really decreased quite significantly. The last case of wild polio in the United States occurred in 1979, and the Americas were certified polio-free in 1994. And we do know that polio vaccination coverages remain fairly high across the United States, even though I know with COVID, there has been a bit of a decrease in parents seeking primary care. We still think that polio vaccine rates remain high. And then in terms of global polio eradication, there has also been tremendous progress. This slide really shows since 1986, the strides that we've made, which has really been an effort of a number of agencies and non-governmental organizations coming together to support this effort. So, you know, due to these efforts, we really saw the last polio case in India in 2011. Type 2 was declared eradicated in 2015, and then type 3 followed with eradication declared in 2019. And then exciting, in Africa, poliovirus was declared on August 25th, 2020, after 4 years without a confirmed wild type case of poliovirus. In the 3 decades prior, it was estimated that 75,000 children in Africa developed paralysis due to infection with wild poliovirus. So this was really truly a milestone for the many children who were paralyzed without a lot of the resources available that we have in the United States to help with that illness. So as of January 2021, really only Pakistan and Afghanistan remained with wild poliovirus type 1. And we were looking forward to a time when type 1 eradication occurred as well. However, in February of 2022, Malawi declared the first case of poliomyelitis due to wild poliovirus type 1 in that country since 1992. And so with that, I'd like to talk a little bit about the response to that discovery in my next series of slides.
And just to interject, there's actually been cases of, I believe it was wild type 1 in a Ukrainian child last December. And in Israel, there was a child who developed polio from type 3, from a vaccine strain that was type 3.
Yes,
Amy, so there is a concern as the war wages through the Ukraine and Russia interaction that it could pour into Eastern Europe if vaccine coverage does drop beneath that 90%, which is required.
Definitely. I think that is a real concern. I thought the Ukrainian child was vaccine derived, but I could be totally wrong.
It could be. I could have gotten it wrong, but there definitely was a case of paralytic polio that had been identified from a Ukrainian child who I believe was not vaccinated, just like the 3-year-old wasn't vaccinated in Israel. And with the amount of people that have been moving out of the Ukraine due to the political turmoil in that region and entering Poland and then going into Eastern Europe in record numbers, that we haven't seen since World War II, there is a concern to start to monitor.
No, you're absolutely right, Amy. And we probably don't even have time to get into that, but so many questions and activities that are really coming out of that mass migration from the Ukraine. I know our team has been very involved in trying to think through recommendations for the United for Ukraine movement here in the United States and trying to bring people over, and what types of vaccines do we need both recorded, and then what will we do here to support that vaccination effort. Okay, so to get back to Malawi, as I mentioned, so the first wild poliovirus type 1 case was discovered in Lilongwe, Malawi, which is the capital city. The child was 3 years of age. She was a girl. She had no history of travel. And of note, she'd only received her birth dose of oral polio vaccine. So at 3 in Malawi, she should have received 3 doses, and she had only received 1 of the 3. She was in one of the sort of peri-urban areas around the capital city. So these are areas where there's a lot of crowding, lots of houses in very close proximity. Water sources and sewage sources are often shared amongst households, so making it a very ripe area for the spread of poliovirus. Interestingly, the date of onset of her paralysis was the 19th of November in 2021. Samples were collected, but it took some time to get those samples to the appropriate laboratories and then sent out to South Africa, first for testing and then CDC for confirmation. So, one of the improvements I think we do need to make moving forward is to try to get those specimens sent more quickly so that we can determine a case of poliovirus more urgently, really much more immediate to when the paralysis occurs. Especially because given that 3-month gap in between paralysis and confirmation, poliovirus continued to circulate in that community. So I thought I'd just take a brief stop and say, where is Malawi? It is a country that Madonna made famous, but I don't know that everybody knows exactly where Malawi is. So it does sit in Southern Africa, sandwiched between Mozambique and Zimbabwe. It has the landmass about the size of Pennsylvania and a population of about 20 million. When I was in Peace Corps, I'm certainly dating myself, but that was in 1993, the population was 10 million. So there is an incredibly high birth rate here, and a lot of the population has essentially doubled in the past 30 years. 20% of the country is water. There is a massive freshwater lake that sits within the Malawian borders, and it's known as the warm heart of Africa because the people in Malawi are incredibly friendly. It's divided into 3 regions. So there's the northern, central, and southern region of the country. The capital city is based in the central region. And as a Peace Corps volunteer and working for Baylor, I spent most of my time in the southern part of the country, and that's actually where I went back to for my deployment. So immediately, once this case of wild poliovirus was discovered in Malawi, the Malawi Emergency Operations Center went on high alert and established sort of a core of people to be able to work a response effort. That includes epidemiologists, it includes social communicators, it includes laboratorians, clinicians, all the types of people you think would need to come together to mount an appropriate emergency response. But then they did ask for assistance from other countries and other public health organizations, including CDC. What they really wanted to do was to plan and implement a national polio immunization campaign, most often referred to as a supplemental immunization activity. So this is an activity that sort of supplements the ongoing routine childhood immunization and doesn't seek out children who have not been immunized. It just plans to do mass immunization of all people within a certain age group within the country. They also established environmental surveillance for poliovirus at 11 sites clustered around Lilongwe and then in some other high-risk areas, conducted enhanced acute flaccid paralysis surveillance, and then one of the keys to AFP surveillance is really following up children with acute flaccid paralysis at 60 days to look for residual paralysis. And that is part of the case definition for a case of poliomyelitis, is that paralysis it's not temporary, that children are still very much affected after a 60-day period. So I wanted to talk a little bit about the multi-country response to this case of wild polio in Malawi. I think very quickly it was recognized that we shouldn't just target children in Malawi, but we should pull in efforts from all of the countries that surround Malawi to make sure that there's appropriate immunization coverage throughout this entire region. You know, factors included in that rationale were the fact that the index case was not fully appropriately vaccinated for her age, that this was an orphan case that was linked to circulation in Pakistan back in 2019. So I probably forgot to mention that. Amy might be able to fill us in, but the virus that was isolated from this case in Malawi was determined to have been linked to a lineage that originated in Pakistan.
Yeah, Pakistan, Afghanistan, and Nigeria, one of the few places where it is an endemic problem still. And it's believed that it got on a plane and had been circulating silently in the country for a while.
Right, yes. So I think 2 years of silent transmission, and the area of most recent circulation was not really known. And so, you know, again, all of these reasons, I think, point to doing something a little bit more broadly than just within the country.
I have a question for Amy. Is Nigeria still classified as endemic for wild polio 1?
I think it's been recently removed from the list, but
Yeah.
but it's still considered a problem site, and it's still on our radar due to the high number of type 2 vaccine associated polio cases that circulate there.
Okay.
Yes, I think, I don't want to misspeak, but I think the last case of wild poliovirus in Nigeria was in 2012.
I think it was a little later than that.
Later than that.
Yeah,
Okay.
I think it was a little bit, I think it was more recent than that. I know 2012 sounds about right for India, but
Okay.
due to the political landscape of Nigeria and the group that keeps kidnapping the women, I can't remember their name.
Yeah, Boko Haram.
Yeah, Boko Haram. Their disruption and their distrust of Western medicine and stuff was what made it really hard to vaccinate in those areas and made vaccine officials targets of death campaigns.
Okay. Get it. Thank you.
Yeah, and then I think the other issue is that Malawi is a landlocked country, and really a lot of coastal trade from Tanzania and Mozambique flows through Malawi to countries like Zimbabwe and Zambia, making that whole area really at risk for polio introduction. So 4 rounds of supplemental immunizations were planned or are planned in these essentially 4 to 5 countries. So the initial rounds really targeted areas around Malawi, but then rounds 2, 3, and 4 are branching out. Tanzania, Zambia, Zimbabwe, and Mozambique will all be included in those supplemental immunization activities moving forward. So Malawi has completed rounds 1 and 2 so far. Round 3 is scheduled for July 21st, and then round 4 sometime in August. So initially, I was actually going over to help with round 3 of the polio supplemental immunization activity, but because it got postponed, there were some other activities for me to do instead. So one was really to conduct active case searching for AFP. Second was to follow up suspected AFP cases at that 60-day time period to look for residual weakness. I helped to set up enhanced surveillance at some of these high-risk sites, both in Lilongwe and along the border areas of Malawi and Mozambique. And then really just to support the Ministry of Health and the Operations Center with anything they needed. So what is enhanced acute flaccid paralysis surveillance? It's really supporting the investigation of any AFP alerts that were reported during those first 2 rounds of campaign. So as I mentioned, rounds 1 and 2 have been completed, and as people went out to vaccinate the villages, they would ask in the village for any cases of weakness in a child, and then they would mark those children for follow-up. So one thing that we really needed to do was to go out to those alerts and see, was this a case of acute flaccid paralysis, collect information and stool specimens, and then mark them for that 60-day follow-up period. We also did a lot of work sensitizing clinicians and health workers on just the identification and notification of AFP cases. So, again, Malawi hadn't seen a case of poliovirus since 1992, and things slide off the radar as new health threats emerge. So one thing that we really needed to do is resensitize all of the clinical staff and health workers to make sure that they knew the process for AFP surveillance. We also did active AFP case searches at certain priority health facilities. So that really involved going through registers and registers of people coming to the health facility and looking through names and diagnoses for anybody who might have been written hemiplegia, paralysis, weakness, and then trying to follow up those cases as best we could. One key thing was that for AFP surveillance in most countries, the threshold of finding 2 cases per 100,000 is considered sufficient AFP surveillance. But in this outbreak situation, that was raised. They wanted heightened awareness, and so they raised that reporting rate to 3 per 100,000 children less than 15 years of age in each district. So really finding 3 children with acute flaccid paralysis of any cause, not just polio, but of any cause, now met that threshold for satisfactory AFP surveillance. So really trying to promote that raised level of scrutiny among the villages was one of our key activities. And then in the middle of my deployment, it turns out another wild poliovirus case was discovered in Mozambique, and this was on May 15th. There was a patient that was confirmed. I don't know if you can see on the slide, but I've marked the location with a red star. This was in the Changara district in the Tete province of Mozambique near the Zimbabwe border. And this corridor, it's called the Tete corridor between Malawi to Zimbabwe through Mozambique, is a really highly trafficked trade route. So not surprising, I think, that a case might have been discovered along those transportation routes. Sequencing did confirm that the Malawi and Mozambique viruses both derived from this lineage linked to the importation from Pakistan to Southern Africa. And that estimated importation time, as I mentioned, was about 2 years ago. So somewhere between July 2019 and December 2020. So again, I think this just confirmed for all of us that poliovirus has been circulating in this area, and then the activities that we were doing were incredibly important. So these activities are not without challenges. I call this my planes, trains, and automobile slide, even though it was more like car, boat, motorcycle. But this just exemplifies, I think, the challenges to get out to conduct AFP surveillance and follow-up in some of these children. We first, had to take a 4-hour car ride dodging cows And then we arrive at the health center only to determine that the village where this child was living was across a river and the bridge had washed away in the floods. So there was no transport to cross the river except by boat. And these boats are really just dugout canoes that somebody pulls across the river. So they throw you and the motorcycle in the boat and they cross the river with you. And then on the other side, you hop on the motorcycle. And then it took us about an hour to reach this child's village by motorcycle. But it was a really happy moment when the name of the child we were looking for actually matched an actual child. And the really good news here, this was a child who had been determined to have acute flaccid paralysis. She was actually absolutely fine. So we could give the mother the good news that this was in fact not polio. I did want to make just one comment on the health surveillance assistants, who are really the backbone of the health surveillance in this, or backbone of the health system in Malawi. It is really incredible to me how we are able to find children. And the reason for that is because even though health services and clinics are very few, each village is assigned to a health surveillance assistant whose job it is to know everything about that village. So every birth, every death, every movement, every house is within the purview of the health surveillance assistant. So when you go to a hospital with a name and you say, I'd like to find this child, that hospital or clinic or health post can find the health surveillance assistant, and they actually in their heads know where that child is. So it actually, even though it seems quite impossible to, given the rural nature of the Malawi countryside, it actually is possible to find children. They are also the people who go out and do these supplemental immunization activities. So the first two pictures here are health surveillance assistants out with their cooler boxes, walking through very, very rural areas to reach villages in order to vaccinate children. And I would say, like, some of them walk about 40 kilometers a day round trip to be able to deliver these vaccines. The picture in the middle is one of the health surveillance assistants on the left-hand side with a group of children that have just been vaccinated for polio. And then finally, the picture on the right is a child who actually did have acute flaccid paralysis, but it was due to meningitis. So she had a spastic paralysis. It was not flaccid, but we needed to follow her up, and her father carried her. They left their town at 3 in the morning. They took a 2-hour boat ride, and then he carried her for another 4 hours to the health clinic so we could do the exam. So just kind of amazes me the kind of effort that people have to go to for healthcare, and the kinds of things they're willing to do to get answers for their children. So I'm almost finished. I just wanted to say, the next steps towards outbreak control are really now to get these round 3 supplemental immunization activities on board. In Malawi, that will begin on July 21st, and then it will be followed by round 4 in August and September. Continuing these enhanced surveillance measures so that we can make sure we're not missing any cases, and then certainly improvements in the specimen shipping and patient follow-up so that we don't miss a case and we can identify them very rapidly. And I would be remiss if I could take credit for all this work. It's just been an amazing collaboration, both with our AFM team, who graciously let me go for 5 weeks so I could have this experience, along with our global immunization colleagues who warmly accepted me to Malawi. And then, of course, all of our external collaborators, including the Malawi polio folks. And then I will say thank you with that. I'm certainly happy to take any questions that you may have about, or we could begin really a dialogue on what comes next. I did not mention, for the sake of time, the wastewater surveillance that detected the vaccine-derived poliovirus in London. I know that's made the news for a lot of folks. So we could also take a tangent down that road as well. But thanks for listening.
Thank you, Janell. This is fantastic. Mark is raising his hand, but before Mark, I would like to invite Amy to make a very short statement, not too long, followed by Roberta and Matt, if he's still here. about the implications of these findings, particularly for our clinical practice. And Mark, go ahead.
Okay, thanks, Carlos. Just two questions, Janell, and thanks for the presentation and for your work in Malawi. The first question, you mentioned the 60-day follow-up. So does that mean a case of acute flaccid paralysis that had resolved by 60 days is not considered a true case?
That's correct.
Okay. And then the second question was, my understanding is there's a newer version of OPV that's been engineered to be more stable so that it reverts less easily. Is that what's being used in this campaign?
Mark, that's a great question. So no, what they are using in this campaign, given the fact that it was a wild poliovirus type 1, is essentially bivalent OPV that contains types 1 and 3. I think what you're referring to is OPV type 2. So the monovalent OPV 2 that's being used for the circulating vaccine-derived type 2 outbreaks. And then that novel OPV 2 that was engineered to revert less. Is that what I'm thinking of?
Yeah, that sounds right. I didn't realize that was just type 2. Okay.
I think it is. I can throw out a lifeline to Bernardo Mino, who sits on our laboratory side, and he, as well as Jen Anstat, who's no longer with us, were really instrumental in doing the studies that showed the efficacy of NOPV2. Bernardo, I don't know if you want to mention anything.
Yeah, the novel OPV, it's called NOPV2, not to be confused with the MOPV2, which is a monovalent version. And Janell's spot on. What is being used here is not, it's bivalent OPV, just to save N. So yeah, the NOPV2 is still under EUL use, and there's limited use. There's also limited availability. So it was not used here.
And 1 and 3 don't revert as frequently. Is that correct?
No, that's not correct. They all revert. They all revert.
They don't cause vaccine-derived polio as frequently. Is that correct?
I don't know that I would say that. Considering, so Phil Minor's seminal study showed that type 3 will revert within 24 hours of vaccinating his son. He did those studies in the early 90s. Type 2 is more I would say it replicates better. It reproduces better than type 1 and type 2 or type 1 and type 3 to some degree. I would say that that's more accurate. There are other reasons why we think that is, but I would say that that's more accurate. And
So Amy, one question, and I'd like to ask Roberta and Matt later. So what are the implications of what we are observing in some countries in Africa and perhaps in Pakistan for the United States from the virology point of view?
so in terms of polio circulation?
Yeah.
So our feeling has been that if you were to sample wastewater here in the United States, you would always find polio. It's more, you always find polio being shed, but it doesn't persist because OPV always replicates within the gut. You shed variants out, and then they don't necessarily always circulate as well. And usually you see blips, but you don't see them as consistent as what we see in London, which is suggesting that there is community transmission of the virus. This has been a problem, and this was a comment first written about by Vincent and Alan Dove in 1997, and then has been on the radar for Questia for even longer. So it's still out there. We just don't monitor.
Yeah.
And so this really implies the importance of keeping immunization above the 90%.
Now, that is a very important point, Roberta and Matt. For us in the clinical setting, when we are seeing occasional patients that are immigrants from other countries with some suspicious neurological problems, neuromuscular problems, and other things. Give us your view what we should do.
Well, I mean, I don't think I have any magical answer, but I mean, we always take a history of where people are from and whether they're vaccinated or not. So it would always be in the differential if there was the right travel history or exposure history for the very reasons that, were just mentioned. But I don't think, isolated reemergence would change drastically what we do in the United States unless, suddenly there was some cluster of cases that was imported or a particular geographic region that had emigres or something from that area. So to me, I mean, it's unfortunate that we see these reversions here and there, but I don't think it would change anything drastically right now. I will say, I just wanted to follow up. If there's one thing I'll take away from this call, maybe I'm the only one on the call who didn't know this, but I am kind of shocked that the 100% revert. I did not know that for OPV.
Yeah.
So if that's the case, what is the rationale for that vaccine? Is it just that it reverts, like it takes a long time to revert, so your body then makes the mucosal response before that reversion occurs? Or like, why would you make a mutant
So
vaccine?
the idea was, so Hillary Kaprowski and Albert Sabin and various other pioneers, they knew that you needed to have protection at the site of infection, which is the gut. The primary site of infection is the gut, and IPV does not give you gut immunity.
Sure.
And so so all of them do revert, but when you look at what is shed, it's not 100% reverted. You can find revertance in every sample, but it's not 100% of what your sample. Does that make sense?
So is the mucosal immunity that you're making to the non-revertant virus or to the revertant virus? I guess that's my question, because
well, it's so anagenically, it's similar enough because the neurovirulent determinant is not in the capsid. It's in the 5' untranslated region, which is the region that is required to initiate protein synthesis or viral protein production. So the capsid, so there is overall in a polyclonal sera, there is enough similarity to protect you. Monoclonals are slightly different.
So the advantage of the vaccine is that there's a period where it is not a neurovirulent strain.
Yes, it is majorly a non-neurovirulent strain. It allows you to make a mucosal immunity so that when you get reinfected, it's like an abortive infection. So one thing that I didn't say at the beginning of Janell's talk is that it's slightly a misconception that it's a sterilizing immunity. We've never made a vaccine that protects against infection. What we've done is we make vaccines that reduce the ability for infection to progress. There's a difference. And OPV reduces the ability of the infection to progress. It's more thought of as to be an abortive infection. Although you do replicate virus and shed it in the stool, you just don't go any further than that mucosal cell.
Matt?
Sorry, I'm going to have to run in a second here. I'm on our clinical service, hence the bow tie, usually not quite this dressed up. I mean, I don't have much to add to what Roberta had said, which is, we always clinically think about things like polio or revertant, vaccine-derived polio in immigrants. So, other than just sort of maybe having this recycled through our memories, more recently now than like if it's been a while since we've thought about it, I don't think it really changes too much. And of course, if we ever had any worry for a true poliovirus type infection, we would be collecting stool samples and sending those off to Bernardo's lab or whoever it is that does the typing if it's not Bernardo. So I think that always would have been something we would do, and it just sort of reinforces for us that it's something to keep on our differentials. Yeah.
Thank you, Matt. Is there any other comment from our colleagues in infectious disorders, Mark, or any other of our colleagues in Europe or in Africa or in Latin America? Or any question for Janell? Well, it looked like it's 3:05. Janell, this was fantastic. Thank you very much for bringing back the discussion about polio, and for Amy and Roberta, Matt, and everybody. Thank you so much for participating. I think the bottom line is, as always, we need to be alert, not only enteroviruses, but any other viruses. And actually, that reminds me that please mark in your calendar. So August 18, August 25th, September 8th, those are the 3 days for the acute flaximyelitis virtual symposium. We are going to schedule between 1 p.m. and 3:30 Eastern Standard Time, and we will keep you updated about the program, and I hope that you are able to join us. So there is not going to be a meeting at the end of July, but we are going to have 2 meetings in August and 1 meeting in September. Well, thank you so much, and stay safe and keep enjoying the summer. Thank you, Janell.